patients are from all over. There are some technical issues in terms of follow-up. But this is basically the depiction of what happens, and this is taken from Jan's review paper in 2005. So what this shows is the cannula and the camera going inside of the womb, and by guiding the camera and the cannula into the baby's airway, you can deploy a balloon, and you just leave it there until the baby's delivered. And what happens by blocking the airway in a baby is the lung starts to grow massively. And that's been shown in a sheep model as well. So this is what it looks like on the fetoscopic view. You actually can see the airway. This is the cannula going in. Here's the balloon being inflated, and then it's basically dropped and left in place. And the most important part, of course, is that somebody who's going to be delivering this baby knows to get rid of the balloon before the baby's umbilical cord is separated. So another new thing that happened in the last 10 years is a biosynthetic patch, a patch that is not made up of synthetic material, and that's the CIS, or brand name by Cook is CHERUBS patch. So this is actually from the wall of the pig bowel. It's the porcine submucosa, which has been irradiated and treated with growth factors. And the idea of this is that it's a scaffold, so that the patient's own fibroblasts, muscle cells, grow in over the scaffold and replace that scaffold eventually with its own muscular diaphragm. And this is a very intriguing idea because obviously many of you know Gore-Tex doesn't grow, Marlex doesn't grow, and so eventually these patches can pull away and you end up with a diaphragmatic hernia recurrence, or as many of you already mentioned, the chest wall doesn't grow symmetrically, so they get scoliosis or pectus deformities. So this is a fuzzy picture, but that's what CHERUBS looks like, stitched in. So it's nice, it's quite supple, and it reconstitutes well. The only drawback is that it actually, the scaffold breaks down in 2 to 3 weeks. So for the very, very large defects, like the agenesis patients, the patient's own muscle cells have not had time to grow into the matrix yet, and so by the time it dissolves, you may still be left with a defect. And that's actually what happened to one of my patients who had actually not one but 2 CHERUBS patches put in just to sort of stepwise provide the scaffold so that he can grow his own muscle cells in. And what's left, I don't want to mislead you, these are not mature muscle cells. They're not a functional diaphragm still. You know, I had the misfortune of going back in the 3rd time and looking at this CHERUBS remnant, and really it's just a layer of his own tissue that does separate the abdomen from the chest, but to say that it's actually a functional diaphragm is unlikely. So no CHERUBS patch, no patch of any kind really replaces a dynamic diaphragm. So for the agenesis kids, they don't have 2 functional diaphragms, they only have 1, no matter what patch you put in. So the other big thing that's been happening is now that we have minimal access surgery, and we're doing a lot of minimal access surgery, we've started doing minimal access repairs for diaphragmatic hernia kids. And we can either do it through the chest, so it's thoracoscopic, through the camera into the chest, or we do it through the tummy, laparoscopic. And the nice thing is, instead of that big incision I saw on your CHERUBS YouTube, all the kids pulling up their shirts, comparing their scars. Well, we now have pretty scarless diaphragmatic hernia kids, and that's because they are 3 millimeter or 5 millimeter incisions, either in the chest or the tummy. And we do the same thing. We use those instruments to put the organs back inside the abdomen. We can patch as well, and they're left with very, very small incisions. And unfortunately, I follow these kids, but I never took a picture of them after a year or so, just to show how nicely the wounds heal. But it's very cosmetically appealing, and we'll be following these kids, so we'll know whether or not by using smaller incisions, they show up with less chest wall deformities. And technically, it's not terribly difficult. You have to position the babies in a certain way, and sometimes the more unstable babies are not so great with lying on their side or slightly tilted, so they're not, unfortunately, great candidates for this. So this is the camera looking from the chest into the tummy. So this is the diaphragmatic hole, and this is the diaphragm. This is the stomach, actually, that you're looking at being pushed. So this is me pushing it back from the chest into the abdomen. And then once they're all pushed back in, we start putting stitches, and actually we start now anchoring the most lateral stitch outside through the entire chest wall, because that's the area that's most likely to recur and has the least amount of diaphragm tissue. So that's an exteriorized stitch that we use for the corner. So once we get that going, it's actually quite nice because the edges start to pick up. And so you see over the defect, we put 4 or 5 stitches in. And that's how it looks once it's done. The hole's gone. So this is a little video. This one is actually a laparoscopic approach. So this is actually going in the tummy, and we actually inflate the tummy with air so that we can get some space. And you can see that it might be hard to see, I guess. So there's a hole, and this is the bowel herniating through the hole, being pulled back out. Sometimes they can be stuck. Sometimes the hole is small, and so we actually have to make the hole bigger in order to pull everything back down. So once that's all pulled back, you're staring into the hole and